The Incredible Years, you guys heard of that? It's one of our University of Washington programs. Another excellent program, hugely well researched. This is, there's lots of different pieces or ways that Incredible Years can be delivered, but I think one of the more popular, the ones that we see most often, are parenting groups. And they have videos and role plays. They teach parents how to decrease problem behaviors, increase positive behaviors in child self-esteem. And this is usually delivered in group settings. So you start seeing themes: decrease negative, increase positive, and all. Triple P is another intervention that's been around for 25 years, although it's only kind of more recently been on the scene here in Washington. But this is a multi-level intervention that teaches parent strategies for improving parent-child relationships, teaches new skills, and teaches them how to manage misbehavior. And what I like about this one is just how flexible it is. So it really meets the parents where they're at. They pick a couple different things they want to work on, and they've been able to demonstrate really effective results there. For older kids, so when I say younger kids, this is more like the 2 to 8 to 10 year range. Triple P says it goes up to 12, but I think probably 10 is a pretty reasonable way to start them out. As a kid, that 10 to 12 is a really awkward age for parenting interventions, because kids that are 10 to 12, there's some of them are more like, the early young adolescents. Some are much more like little kids, as far as their where they are developmentally. And so you really have to, I think at that age group, you kind of have to think, do you go to some of these earlier programs, or is the kid kind of at the level of severity or concern, or they're acting a little more in line with some of these kind of older kid interventions. We have a hard time placing or figuring out good interventions for that age group. But for older kids, so here you'd be looking at the 11, 12 to 17 year range. You'd be looking at things like functional family therapy, multi-systemic therapy. And these are really full family interventions or ecological interventions that involve the family. They often involve the kid as well. And then in the case of multi-systemic therapy too, sometimes it involves the schools, the other people that are existing in the probation officers, anybody else that might be involved in this kid's life that could potentially leverage some of those contingencies that we talked about earlier as being so important. We also have family integrated transitions, which is an adaptation of MST that Wayne directs, and that includes also dialectical behavior therapy, relapse prevention, also with a kind of overlay of engagement strategies as well, recognizing that a lot of kids that are coming out of juvenile JRA, Juvenile Rehabilitation Association, have really hard challenges with emotion regulation, and so there is some work to be done individually with the kid there. And then a program that Shannon and I have been involved with, which actually could be this one could actually span that like 8 to 14 year range, is Match ADC for anxiety, depression, and conduct. This would be the conduct piece of the ADC. It's a modularized treatment that's available. Right now it's just available in 2 different areas in Washington. But we're excited about this as a potential option for kids that have comorbidities, so they have conduct problems and depression or anxiety. It's a very flexible treatment there, and we're going to talk a little bit more about that later. And then also just a reference to aggression replacement therapy. This is one of the only ones that's up here that is just for kids. It's just a youth-centered intervention, although because the kids are a little older, they do have some findings that show that this can improve kids' behavior. And it's really teaching kids new ways of thinking about as a cognitive, skills-based approach for dealing with anger and risky situations. So those are kind of the specific problems that are being addressed there. So with that, I'll turn it over to Shannon. You guys use that?
Okay. So one thing that you'll notice is that we have a lot more treatments that are available for the externalizing behavior problems as we move into this. Why do you think we would have more for the externalizing problems than internalizing? Who do externalizing problems bother?
Teachers.
Teachers. Who else? Parents. How many times have you seen parents really complain about a sad kid who's really sad or worried? I think there's a little less worry there. The outcomes are negative, but they're not as negative as what some of the early externalizing problems are that go untreated. So as you'll see, it's so exciting when we go through externalizing because there's so many options that we can present. And then when we move into internalizing, there's a few less very specific programs. So the main thing to keep in mind whenever we're going to talk about internalizing is just that cognitive behavioral treatments are the way to go. And cognitive behavioral treatments just do the cognitive triangle, where you're focusing on the connection of thoughts, feelings, and behavior. And a lot of the ones that Sue just presented on, they're predominantly behavioral, but they may have a cognitive piece. But when you get to the anxiety and depression, it's a big B and a big C, if that makes sense. Sometimes we talk about big C, little c, big B, little b. And so there's a lot of cognitive work as well as behavioral work. But the behavioral piece can't be forgotten about. So I think sometimes what happens in community practice is treatment of anxiety and depression looks very cognitive, talking about worries, talking about fears, talking about being sad, new ways to think, but the behavioral can get missed. So there's a huge piece when you think about treating anxiety and depression of a behavioral intervention. So with anxiety, it's facing your fears. Lucy Berliner, who started this series off, she always says with anxiety, and I love this, that facing your fears is the cure. So if we withhold assisting kids with facing their fears, whatever that is, separating from parents, a difficult memory, fear of the dark, if we withhold facing the fears, the behavioral piece, then we're withholding the cure. And so I think that's kind of a neat way to think about it. And then there's a big behavioral piece with depression, and that's behavioral activation. So we'll talk about that in just a second. But without those behavioral pieces, the CBT treatments for anxiety and depression aren't very effective. So it has to be the cognitive as well as the behavioral. It can't just be talking. And that cuts across all the interventions. So all the ones that Sue talked about already for externalizing behavior, the therapist and the parent are very often out of their chair. There's the coaching in PCIT, there's role plays, there's practice. And when you do these as a therapist, you've got to have people practice. And when we train therapists, we have to have them practice. The one I realized we didn't mention on the externalizing is helping the non-compliant child, which is also a UW program. Not very widely available, but we taught about 8 or 9 students as part of the same initiative in the fall to do helping the non-compliant child. And it looks a lot like those externalizing externalizing treatments that Sue presented.
And we are going to be teaching that again this fall. This is a plug if any of you guys are interested.
So that'll be in the fall. And it's great. So we've got a lot of these programs, but they all look like get out of your chair, practice things, try new things. There's always homework, there's always an agenda. So that cuts across all of these. So, interestingly, caregiver involvement is required when you're talking about a behavior problem. When you're talking about anxiety and depression, we like to have caregiver involvement because we need them to understand what the kid's going through, and we need them to support the child using contingencies and changing the environment and trying new skills, new behaviors, and new ways of thinking. But really, the active ingredient for treating anxiety and depression is often the one-on-one work that the therapist does with the child. So that's in somewhat contrast to the behavioral intervention for externalizing behavior, where you would not want to do only one-on-one work with the child. So, again, I mentioned we do a lot of talk about thinking. I know, it's turned into a black cloud. So working with kids to not have so many black clouds. One piece that I think is important to bring up whenever you start talking about internalizing with kids is just that medication, a lot of kids end up on some sort of medication, and it's not recommended as the primary or only treatment. We always recommend that the kid should also be in therapy. Antidepressants have gotten sort of a negative rap, but they can be effective and relatively safe, but other medications have less support, and in almost every single case, polypharmacy has absolutely no evidence, nor is it indicated. So one thing we train caseworkers in is anytime you see polypharmacy, especially in young kids, ask questions. So in terms of depression treatment specifically, again, you see less of a laundry list of various programs that are available. But one is the Match ADC, the depression part. And that's where therapists work individually with the child to identify unhelpful thoughts, to learn new skills like relaxation and behavioral activation, which is just sort of a fancy way of saying engage in positive activities. So we see this with people who are depressed. What do people who are depressed want to do? Are they more likely to want to go to the gym, go to a party, or stay at home and sit on the couch?